Today we have a real treat to hear from Tom Shea, who I think probably everybody in the room knows. But I want to give Tom a little bit of an introduction because he has a very distinguished background and list of accomplishments that you may not know of. Tom was an undergraduate and a medical student here at UNC, graduated AOA and went off to Harvard where he was a resident and Hem-Onc fellow at Beth Israel. From where it sounds like after a year on the faculty, he was recruited to UC San Diego, where he developed and started their bone marrow transplant program. He then was recruited back here to UNC to do the same thing and has developed really one of our most outstanding transplant programs and has been a leader here in clinical oncology in the division and in the cancer center, has been a leader nationally in bone marrow transplantation and stem cell transplantation, and has many, many publications and talks all over the world on these topics. We were also just talking for a moment. I didn't know, I guess I hadn't looked at his CV in a long time, that he spent a year immediately after medical school in Nicaragua as sounds like a multi-purpose physician there for a year and had a great experience. So some of you who may have interest in international experiences might want to speak to Tom about that. So it's great to have one of our own faculty who's such a distinguished and outstanding world leader in his field to talk to us today, and he's going to talk to us about blood stem cell transplantation in 2008. Thanks, Tom.
Thanks, Marshall. Thanks. I guess it's time to ask for a raise. Thanks, Marshall. That was great. So, anyway, but one cute story about Nicaragua. People do look through my CV and they say, "What were you doing down there?" Well, I was working in a mission hospital, and I was supposed to be there for 2 years. And to make a long story short, I was on the east coast of Nicaragua on the Caribbean side, which is really a pretty separate world from the west coast, which is around Managua. And most of you may or may not remember, but in 1979, there was a revolution going on down there, and they pulled the Peace Corps workers out. And while I wasn't with the Peace Corps, there were some Peace Corps workers with me. And so when they disappeared, we kind of scratched our heads because where we were really was not at all involved in what was going on politically until they left. And then the second thing that happened that year was that every spring they have a baseball tournament in this town called Puerto Cabeza. Now, most of you may not think that baseball is a big sport in Latin America, but in fact in Nicaragua, partly because we've been there as a U.S. presence for many, many years, baseball is their national sport. So people would always talk about how, the country kind of shuts down and everybody sends a team and it's like the festival and, this should really be great. And so we were looking forward to it. Well, unfortunately, in the spring of 1979, instead of the baseball team showing up, troops started showing up with half-tracks and tanks, and I thought, well, this is quite an unusual baseball tournament. It's even worse than the Red Sox and the Yankees. And so I think maybe I better get out of town. So I actually ended up leaving on the last plane out of the town that I was in 3 days before they closed the airport in Managua as the troops are surrounding and people were coming to close us. So anyway, I got out just in time to come back and become an intern. And the second part of that story was I hadn't yet arranged for where I was going to be because I was supposed to be there for another year. So Bob Ney, who was the chairman of medicine at the time, and I managed to match outside the match by shortwave radio. So that was another sort of interesting wrinkle where I said, I need to come back over. And he said, okay. And that was about it. So anyway, I guess the rest is pretty much the way Marshall described it. So I'm happy to go ahead and talk today a little bit about transplantation. Unfortunately, because the house staff don't really rotate through the BMT unit, most of you only know me through the ICU, which is fortunately not where most of my patients end up, but certainly some do. So I appreciate the work that you folks do in taking care of them through their often darkest hours. But the good news is that a lot of them, number one, never make it, and some of them make it and then come back out. And so, never make it to the ICU, but secondly, a lot of them do come back out of the ICU and end up going on to being productive afterwards. So thank you for what you do for our folks. So with that, let me go ahead and talk a little bit today about who you should transplant, when they should be referred for transplantation, and then finally some of the data that would suggest why you should transplant them. How do we end up doing from a treatment standpoint? And so the topics that we're going to cover today are a little bit of an update. What are some of the advances and indications, factors that influence the outcomes? We'll talk about some of the comorbid illnesses briefly. When do you refer folks for transplant? What is the process? And I won't go into that in much detail because I realize that as general internists or as non-Hem-Onc subspecialists, you're really not going to be making too many of these referrals. but certainly if you're in any kind of a primary care field, your patients are going to be coming back to you at some point and say, what do you think I should do? Because you're the people that they're accustomed to talking to over the years, and so I think your input can be very helpful. Finally, what about the search process? Why does it seem to take so long when you don't have somebody within your family as a donor? And what are some of the resources that could be available to help you make that decision and to make it available for your patients? And so as we go through the indications for transplant, this is a few years old now, but this is data that's been generated and collected by what's called the Combined International Bone Marrow Transplant Registry, or CIBMTR. And the long and the short of it is that the allogeneic transplants are in yellow, the autologous transplants, where people use their own blood cells, are in green, and then this is the cumulative number of transplants for the different diseases that are spread out here along the bottom. So for instance, multiple myeloma is a single commonest indication for why we do transplants. That number may have changed a little bit as non-transplant therapies for myeloma continue to improve, and so that's always an issue. For instance, CML used to be a disease, or chronic myeloid leukemia, that we transplanted quite frequently. We almost never transplant CML patients anymore because of the advent of imatinib and some of the other tyrosine kinase inhibitors. So, the good news is that it's a group of patients that no longer need transplant. The bad news is that they actually used to be some of our most successful groups of patients. So as you take away the low-hanging fruit, if you will, then sometimes the transplant outcomes look a little bit less good. But down here we talk about myeloma, lymphoma, acute myeloid leukemia, Hodgkin disease, ALL, and so on. And not surprisingly, some of the diseases like myeloma and lymphoma tend to be more frequently transplanted with autologous cells, and then only a smaller percentage of the NHL patients are treated with allografts. However, acute myeloid leukemia, most of transplants that are currently being undertaken are using allogeneic donors as opposed to autologous. And then from left to right here, you can see the other diseases that I've listed. So if you look at the aggregate number in North America, at least in 2003, we did about 7,300 allogeneic transplants and about 9,000 autologous transplants. Now, what about cord blood transplants? You've all heard about umbilical cord transplants as being something that is an increasing option for our patients. I won't go into this too much because, partly because Duke University has done a lot of cords, particularly in their pediatric program, and now more recently in their adults. That's not really something that we've gotten into in a big way. But most of this data is based on pediatric patients who've gotten cord blood transplants. But you can see now in the year 2006, a significant number of patients have actually gotten cord blood transplants, somewhere in the range of 400 to 500 in North America during that time. So not nearly as frequently as what you would see with adult stem cells or bone marrow, but nonetheless an increasing source of cells for us for the appropriate patients. And this is just looking at the aggregate numbers, both autologous here in yellow, and then the light blue are the allogeneic patients. And a couple of things that you can see here is this spike in the patients getting autologous transplants. This was the peak in the late 1990s when people were doing more transplants for breast cancer. And then when the randomized data came out suggesting that there really wasn't a survival advantage for people getting autologous transplant and high-dose therapy for that disease, the numbers dropped off, really quite dramatically. And I think that that's why you see it going back down here. Now the number has kind of steadied out here at around 30,000 a year worldwide and about 15,000 a year for allogeneic patients. And so those are the kind of numbers that you look at if you look at it globally. Now what about the NMDP? Well, the NMDP stands for the National Marrow Donor Program. And this is looking at unrelated transplants by product type. And so we're talking about the blue being bone marrow, the dark orange here being peripheral blood stem cells, and then yellow being cord blood. And the reason that I put this up here is that this reflects, I think, what has happened in our field over the last 10 to 15 years, where increasingly we've gotten away from using bone marrow for patients both in the autologous transplant setting as well as in the donor transplant setting. And instead of using bone marrow and collecting marrow from their hips, instead we're using peripheral blood stem cells that are usually mobilized from their marrow, and then the cells float around in the peripheral bloodstream, and you can collect them through the pheresis process, which is really not very different than when somebody goes down to donate platelets. Cells are taken out of one end of a Hickman catheter or through one IV catheter, circulated through a centrifuge. We hold on to the white blood cell component that has the stem cells in them, give the patients back the red cells and the liquid and the platelets, and it all kind of goes through a closed loop procedure over a period of about 3 or 4 hours. And in most cases, for an autologous patient, we can usually get all the cells that we need in about 2 of those sessions. For donor transplants, about half the time we get them in a single donor setting, and then in about another 30 to 40% of the time we have to collect a donor twice. But it's very rare to need to collect a donor more than 2 times in order to get enough stem cells for them. And the advantages of the stem cells as opposed to bone marrow is mostly that it tends to increase your rate of recovery in terms of engraftment. And so people recover their blood counts more quickly, and everybody likes to see the counts recovering after high-dose chemotherapy or radiation because that reduces the risk of infection. And so that's why starting around 2000, the frequency with which we're using peripheral blood here in orange is much, much greater now than what is the case with marrow. Now you see this little blip here on the last, and this is the last thing that I'll mention here, on the right-hand side rather, and that's because one of the downsides that we've learned about with peripheral blood, and if you think about it, it's not a big surprise, peripheral blood has a lot of T cells in it. Well, T cells are the component of the immune system that are capable of transmitting graft versus host disease and are the culprit, if you will, in terms of GVH and its complications. When we've done peripheral blood cells, yeah, they do recover more quickly in the recipient, but there's also a higher risk of GVH, particularly what we call chronic GVH, which tends to last anywhere from months to sometimes years. And so as we start to look at our data now, there are some groups, such as those with aplastic anemia, where you're really not so worried about the disease coming back. You just want to make sure that they don't drop their graft, and you'd like to have them not have very much graft versus host disease because that diminishes their quality of life. So at least now in the pediatric population, there's pretty clear data that bone marrow gives you a better outcome than peripheral blood does, and so we're starting to adopt that again in the adult side of the equation. But it's a little bit more complicated because adults don't do as well with prolonged periods of aplasia, so if you actually have your counts recovering more rapidly, there's some advantage of that in a 50-year-old that may not necessarily be the case in a 10-year-old. So we're trying to balance those things out, but that's why the field continues to change. Now, the registry is something that's pertinent for everybody, not just medical people, but this is something that you probably will hear about from patients over the years because you will, for better or for worse, often be the experts in terms of who they would turn to for this kind of a question. And so this is the unrelated donor registry, and this is what happens when you go to either, used to be the Red Cross, now the NMDP is actually doing the process themselves. But you get your blood drawn, and then it's sent for HLA typing. And then if your HLA typing is successful, they go ahead and enter you into the computerized registry. And then your HLA type is out there for potentially anybody who would need an unrelated transplant at some point in the future. So a year after you donate, in fact, you might be called to say, are you still willing to donate? We have a potential patient. And then you have to go through a more elaborate screening process, making sure that you haven't traveled to Europe, and been exposed to mad cow disease, or if you have, I have to sign a special form that says, yeah, it's a risk, but my patient has leukemia. It's more important that he get a matched, marrow than the fact that the donor might have mad cow disease. And so, those are the kinds of things that we go through from a safety standpoint. If you do enroll in this, though, then you may be called. And so I would just encourage people, number one, to enroll, but number two, to think about it, because oftentimes people say, can I donate for my cousin, or can I donate for somebody that I work with? Well, when they donate into the registry, it's not directed for an individual person. And there's only like a 1 in a million chance that any particular person is going to match you from an HLA standpoint. So that's not a good plan. But if they're in the registry, they may well get called and then asked to donate for somebody else. Briefly, I would tell you that the current data suggests that for Caucasians, there's about an 80% likelihood of finding a well-matched donor through the National Marrow Donor Program. If you're African American, that number is about 60%. If you're Hispanic or Asian, that number is about 50%. And so we particularly are trying to increase the number of people from minority groups in order to increase the likelihood that patient pool will be able to find an adequate donor for transplantation. And now we have about 7 million people in the registry in the U.S. When we do start to look for somebody for a potential unrelated donor, we first start here, but then it automatically kicks over into registries in Asia and registries in Europe. So when you first start doing your screen, you actually have access to about 14 million donors around the world from whom you can potentially pick a well-matched person. We frequently get donors from Germany. That's not an uncommon place for whatever reason, but that's where I'd say probably maybe a quarter of our unrelated donors seem to come from Germany. All right, so what about some of the other components of transplant? How are we doing these days, and are we doing better than we used to? Well, one of the things that has been very important, particularly when you go outside of the related donor population. So, if you have a brother or sister, there's about a 1 in 4 chance that any individual sibling will be a match for you. Obviously, if you have 10 siblings, then your chances are better than if you have 1 sibling. And so oftentimes we end up having to look through this unrelated registry. But in years past, the typing was not really that good. And so what you'd end up having was a lot higher incidence of graft rejection, graft versus host disease, all the immune problems that had to go into the HLA disparity between the donor and the patient. Now with the some of the more elaborate immunologic testing that we do from a DNA standpoint, we're actually able to find allelic matches at a much higher frequency and are able to find better matches than used to be the case. And because of that, we've really had a marked reduction in transplant-related toxicity and an improvement in overall survival, particularly for our unrelated population. Other cell sources that I alluded to, we talk about umbilical cord cells that are available. There are not many progenitor cells in a cord unit, and so part of the problem with these cells when they go into a recipient, the good news is that they really are immature from an immune standpoint, and so the risk of GVH tends to be much less if you are looking at a well-matched cord than if you're looking at a sibling or an unrelated. The downside is that those same immune cells really don't know what they're doing. They haven't ever been educated, and as adults we don't have thymuses, and so the whole issue of immune reconstitution tends to be much delayed in people getting cord bloods. Plus, there aren't very many of those cells, so the actual duration of time that it takes for the counts to recover also tends to be longer. So that combination of things is partly why adults, at least, have had a harder time with successful outcomes in a cord blood setting than has been the case for children. Nevertheless, I think that we're now doing double cords in patients. That's looking better. And I think that there is continued efforts to try to expand the cord blood population so you're infusing more cells, and maybe that will allow earlier engraftment. Some of the other factors have had to do with some of the newer regimens that we're using. One of the things that we've kind of realized over the last number of years is that not only is the transplant valuable from the standpoint of the chemotherapy and the radiation in terms of getting rid of residual disease in the recipient, but it also actually brings to bear, at least in the allogeneic setting, the fact that the immune cells coming in from the donor do exert an anti-tumor effect in the recipient. And so in everybody's studies, people who get a little bit of graft versus host disease also have a lower relapse rate than people who don't get any graft versus host disease. So we kind of said, well, if you have somebody whose disease is in remission, but you know that in the long run they're not going to do well because they've got a very high likelihood of recurrent leukemia, for instance, then maybe we don't need to come in and beat them up quite so badly with high doses of radiation and chemo, but as long as we could suppress their immune system enough to allow the donor cells to get in and set up shop, we can capture that immune benefit without as much toxicity. So those are what we call reduced intensity transplants or non-ablative transplants, and increasingly that has allowed us to treat patients who are older with less toxic approaches that has resulted in expanding our potential patient pool. Post-transplant complications, always an issue, and certainly help from our friends in infectious disease as well as people in transfusion medicine, using many more products as we need to for a longer period of time. Therapy for things such as CMV, which used to be a real problem, now is almost a thing of the past. It's quite uncommon for us to have a patient die from cytomegalovirus any longer. And then the improved treatment and prophylaxis for fungal infections, agents like voriconazole, posaconazole, which are much less toxic than the older amphotericin-based products and every bit as effective. And so this kind of puts some data behind the issue of reduction in mortality. This is looking at 1-year treatment-related mortality over time by donor type. And the autologous patients are here in white. On the left-hand side here is the frequencies, so 0%, 5, 10, and so on. And then here in blue are the HLA identical sibling transplants. Here in green are alternative related transplants, okay? So these are people who are brothers and sisters but maybe have a one antigen mismatch or something like that. And then here in yellow are the unrelated transplants. And so the things that you need to look at in every case, whether it's autologous or one of these other donor transplant settings, we've now reduced it quite a bit. And I would say even between 2003 and now, the 1-year mortality is quite a bit less than it used to be. In fact, I just presented some data at the National Hematology meetings on a cooperative group study in people with follicular lymphomas getting donor transplants. And in a multi-group setting, so this is now 11 hospitals, across the country, we had a 2% 6-month treatment-related mortality. So we had one person out of 45 die across all those centers in the U.S. So I think that we now are able to do these transplants much more safely than we used to. Unfortunately, still, we have recurrent disease and some of the later complications that continue to present us with challenges. Looking at 100-day mortality, so not just the 1-year mark, but now what happens in the first 3 months. The point behind this slide is that if you look at the different diseases here, one of the things that, in addition to the quality of the match and so on, that becomes an issue is how active is their disease. And so people in first remission tend to have a lower mortality rate than people in second remission, and people who are frankly not in remission, so who have refractory disease. Their leukemia is getting worse while you're trying to transplant them. Well, as you can imagine, they have lots of problems because they're already infected, they're already thrombocytopenic, risks of bleeding and things like that become a real problem. So we'd like to try to take people when they're in remission. That's really important. But the whole issue of whether you take them in first or second remission is an important part of what we try to decide to do, because you don't want to transplant everybody, because despite what I'm saying about advances, you never undertake a donor transplant without really thinking hard about it, whether or not they're going to need it or not. And so I think that there's always going to be a risk of mortality, and so we only want to take the high-risk patients in first remission. We tend to take everybody once they've failed, because at that point their disease is almost certainly going to kill them. And so this is really something that holds throughout the group. The point here is that myelodysplasias, aplastic anemias, immune deficiency states, all of these folks have anywhere from a 10 to 20% 100-day mortality when you look at the identical setting. If you look at unrelated transplants, the numbers are pretty similar, with, again, mortality rates that can be as high as 30% in the folks who are not in remission. It drops off a little bit, but still you're talking about a 10 to 20% 3-month mortality for any kind of an immune-mediated process because of the risks of GVH, graft failure, et cetera. And so what about the issues of patient selection? Well, I talked a little bit about how using some of these less intensive regimens, we're now able to treat older patients. We're now able to treat folks with comorbid conditions, so people with creatinines of 2. We not infrequently take them onto transplant without thinking too much about it. People who have a prior history of heart disease and so on, that's not the absolute contraindication that it was at one point, because these less intensive regimens are really pretty well tolerated for the majority of folks. Having said that, taking somebody who's 60 onto a donor transplant, even if they get through their first few months without much trouble, when they start developing graft versus host disease at months 4 or 5, that's not an easy thing to manage, because opportunistic infections, all the antibiotics that they need, really do take their toll on people with any kind of comorbid conditions. And so that's why I think that we are encouraged by the early success, but need to keep working on some of the later complications. And I think as we talk about some of these treatments that are now safer, we can talk about expanding this to include folks with genetic disorders. There's some data on renal cell cancer that for the most part has proven after an initial flurry of interest to not be particularly effective, so it's really not something we're doing very much anymore. Sickle cell disease, I think, as Dr. Oringer here in the front row knows, has had some good years and bad years in terms of transplant, but I think that for people with high-risk disease, people who've had prior strokes, people who have frequent chest syndromes, where their morbidity and mortality with standard therapy is quite high, this continues to be an option that in the right setting can be considered for both adults and children. And then thalassemia and autoimmune diseases. Again, this, like the renal cell data, is a group of diseases like with lupus and multiple sclerosis that has kind of had waxing and waning interest over the years. The idea being that if you can disrupt and intercede with a new immune system, then maybe these folks can break their cycle of chronic autoimmune complications. And I think that for a short period of time you can do that, but I think that the long-term results have been somewhat disappointing. They usually revert to whatever their underlying disease is within 3 or 4 years. Now, what about the use of unrelated donor transplants? And this just kind of gives you an idea, again, that with the changes in approach, we're now starting to look at increasingly frequent transplants for people that are quite a bit older than used to be the case. And so what we're looking at here is in light blue are the youngsters, 0 to 5 years of age, children. These are older children. Now we're talking young adults, and then people 50 to 59, and then folks older than 59 years of age. And perhaps the most important thing is that not only is the entire aggregate number of patients going up, but now you're starting to see a not infrequent number of patients that are being transplanted in their 60s, not only with autologous transplant, but also allogeneic transplants. And so I think the oldest allograft that we've taken on has been, first allograft was somebody 67. We actually transplanted a person a second time at the age of 70. And so I think that, people, you can debate whether it's a good thing or not, but folks who are otherwise in good shape, we will consider this up to the age of 70, even donor transplants for them. Now, developing a treatment plan and some of the other factors that you have to consider, well, the issue of timing of the transplant is perhaps the most important one. You'd like to try to get the patient when their disease is pretty stable. You'd like to also go ahead and time it when it's appropriate for their disease. And I alluded to the issue of first remission, second remission, and so on. And so we'll get to more about specific diseases in a minute. But that's a big part of what we do, is trying to figure out what the right time is for a particular person. And then the treatment plan is you want to look at transplant as a component of what they may have in store for them, whether it's for a non-malignant disease like aplastic anemia or whether it's for malignancy like acute leukemia. You may not want to start going down the transplant road, but you want to try to not burn your bridges, because depending on the disease, for instance, aplastic anemia can be successfully cured without transplant about a third to 40% of the time. But that means that even when you use cyclosporin and ATG, more often than not, at some point their graft is going to fail, and you're going to have to be looking at this. So you don't want to do things that are going to preclude transplant down the road. Likewise, for folks with acute leukemia, if you wait until they have absolutely refractory disease or in fourth remission, well, you're probably not going to do very well there, because the biology of their cancer is such that even with a successful quote-unquote transplant, you get them out, but they're going to relapse. And so we really need to try to look at what the appropriate involvement is. May not be in first remission, but perhaps in second remission or beyond, and have that discussion early so you kind of know where you might be going. Now, what about some of the issues of when to consider? Well, this is data that has basically come out from the National Marrow Donor Program and the American Society of Bone Marrow Transplant. That's what ASBNT stands for. You can look up some of this online to see what are the general recommendations, but it's really kind of a summary for what I was just talking about, and it's kind of timing is everything. You don't want to transplant people who don't need it, but you also don't want to wait until it's no longer a functional alternative. So for acute leukemias, we talk about people that have high-risk disease, and it could be, for instance, folks who have prior myelodysplasia. If you've got a history of MDS and then develop AML, your likelihood of a durable remission is less than 10% with standard chemotherapy. And so that group of patients, once you get them into remission, you're looking pretty hard to try to transplant them if you can. And the results with transplant would suggest cure rates as high as 30 to 40% in that setting, and sometimes even higher. Treatment-related leukemia, somebody who's had Hodgkin's disease and now 8 years later has developed an AML, well, that's also somebody who is not going to do particularly well with standard chemotherapy, so we would consider transplanting them. Folks who have undergone their initial treatment with, for instance, idarubicin and Ara-C or daunorubicin, but still on day 14 they've got residual leukemia. Well, if you look at the results for that group of patients with AML, they're not going to do very well long term, and so that's somebody that we would then shift gears and not think about consolidating them, but think about transplanting them. People with bad cytogenetics, people beyond first remission in CR2 or beyond are folks that we would consider to be candidates for transplant. Myelodysplastic patients here, this changes a little bit, but by and large, folks with high IPSS scores, being either those who have high intermediate or high risk, they have a median survival of 2 years or less. And so that population of patients, once you've identified them as having these factors, either high-risk cytogenetics or an excess of blasts in their marrow, or trilineage cytopenias, those are all factors that would tend to portend a poor prognosis for people with myelodysplastic syndromes, and so should be considered for early transplant. Lymphoblastic leukemia, a big difference between adults and kids. There are people who would say that just about all adults should be considered for transplant, certainly folks over the age of 30, people with high white counts, people with certain translocations, such as those who have the Philadelphia chromosome or the 922, are high-risk patients and should be considered for transplant. folks with high white counts, people who have CNS or other sites of extramedullary disease. And again, this is quite different than the pediatric world, where most of those kids do get successfully cured with standard therapy. But in adults, the best we can do for ALL is about a 30% cure rate, and that's in low-risk patients without transplant. So if you can transplant them, some data would suggest as high as a 40 or 50% cure rate for even higher-risk populations of patients. Now, what about CML? And this slide is having a hard time keeping up with the success of Gleevec. But the point is that we rarely transplant people until we've given them a trial of a tyrosine kinase for at least 3 to 6 months. People who have failed to achieve a complete cytogenetic response within a year are generally considered at least evaluable for transplant, although there is data that says that even if they've still got abnormal cytogenetics but are continuing to respond, sometimes it can take people as long as 18 to 24 months to respond. So this is a group of patients that I think is still in transition, and we tend to make sure that the patient tells us that they need to get transplanted by biology that is pretty aggressive and not responsive very well to any of what's now 3 tyrosine kinase inhibitors that are available for this disease. Now, in the pediatric population, there is data from a randomized trial in the Children's Oncology group that says that even people with normal risk AML, even kids with normal risk AML, have a higher likelihood of cure with an allogeneic transplant in first remission. You don't have to have high-risk cytogenetics, and that in a comparative trial, they tend to do better than people who just got standard therapy without a transplant. That's been hard to prove for the garden variety adult, but in the kids at least, AML is a much worse disease than ALL, and all things being equal, they tolerate their transplants better than adults do. So the randomized data suggests that the majority of children, at least with AML, should be considered for a first remission allogeneic transplant if you can find an adequate donor for them. Now, again, in pediatrics, you've got to look at some higher risk features. We won't go into it in too much detail, except, again, things such as the pH positivity or very high white count, or failure to achieve a remission at a month. So if you still have residual disease after your initial induction, then those are all risk factors that tend to be associated with a generally poor outcome. So even in kids, you would consider them for first remission transplant candidates. Now, what about the lymphomas? Again, these are not necessarily folks that you're going to be seeing unless you're an oncologist, but there are criteria that are set up for follicular lymphomas, for the large B-cell lymphomas, and for mantle cell lymphomas. I think people will argue a little bit about whether you should be doing autologous transplants or whether you should be doing allogeneic transplants. The long and the short of it is that autologous transplants always have a higher risk of relapse. Allogeneic transplants always have a higher risk of treatment-related mortality. And so we are basically trying to balance, how bad is their disease? If they have a real bad disease, we're willing to do an allograft because the relapse rate is going to be a little bit lower, but we know that their overall survival may not necessarily be better because of the toxicity. On the flip side, if somebody has got a disease that has a high probability of coming back but is sensitive to standard therapies, then we will normally try to recommend them for an autologous transplant, which is much safer and in the long run tends to give better results for the majority of people with these less aggressive tumors. Hodgkin's lymphoma, if you don't achieve an initial complete remission or if you recur after that, then we would consider Hodgkin's disease as a potentially transplantable disease. Multiple myeloma, this again is a work in progress because just like we talked about the treatment for follicular lymphoma with the addition of antibody therapy, or when I went back before and talked about breast cancer treatment, people will argue now a little bit about myeloma therapy because we have many more options than we did 10 years ago, and you can keep people alive for a long period of time, even if you're not going to cure them, but with drugs such as bortezomib, Doxil, thalidomide, Revlimid, things like that, which you've heard about, and certainly on 6 East, you'll see people with myeloma coming in and being treated with those drugs all the time. So I think this continues to be a work in progress, but suffice it to say that most of the data suggests that transplant does prolong survival, but still doesn't cure very many patients with multiple myeloma. So we still recommend it, but really with the idea that it's good palliation, but not necessarily a cure for them. So what are some of the factors that go into success? Well, we talk about the issue of, sending appropriate records. You got to make sure that you have all the data that you need. Is this treatment related or not? Those are the kinds of factors that go into providing a wizened recommendation, if you will. We talk about HLA typing, and so getting the typing done sooner rather than later. There's no reason not to try to type a patient when they first present with acute leukemia. You don't know whether you're going to need it or not, but once they become hypoplastic, then it's hard to get their cells. Now, having said that, we all watch CIS, and in fact, yes, you can actually do buccal smears now and get HLA typing on people through that. And this is really, I think, going to improve our ability to send samples, to brothers and sisters who live in California. And so all the time we're now starting to do that, and the NMDP is doing swabs as opposed to blood draws in order to do HLA typing on potential donors. We talk about using changes in the patient status. It's important to make sure that as you're in communication with a referring physician, particularly if somebody's being treated off-site, that you kind of keep them abreast. And Gene Arnger and I were just talking about now with the ability of them to have access to WebSys. Well, it's really very nice because then the referring docs, not only do they know what's going on, but they can also help round up the siblings because they know kind of what you're thinking and you can communicate them that way. So I think these are all changes for the good. Now, other things we talk about, the consultation process here, we've kind of gone through this, so I won't go through it in much more detail except to say that when we meet a patient for the first time, the biggest discussion we have is to actually kind of review the options. Why should you be considered for a transplant? And then we're talking about an autologous or an allogeneic transplant. I always emphasize with patients when we talk about a donor transplant that it's a kind of a long haul, and we don't know whether you're going to have a hard course or an easy course, but it's really important to have the whole family, to kind of have your support system on board, because when you're on 15 medications for 6 months, I can tell you that everybody says if I see another pill at some point, I'm going to shoot somebody. And while you want to try to keep that from happening, you also want to make sure that there's a support structure in place to keep the person taking their GVH drugs or the posaconazole or whatever it is, because that can make the difference between life or death in some of these complicated situations. All right, so what about outcomes? And this is the part that we say, okay, why should you transplant somebody or why should you refer them? Well, this is briefly some data from a Italian study. And what we're looking at here is some of the current data on whether or not transplanting patients with an autologous transplant first and then an allogeneic transplant second. So you actually separate these by 3 months and then do that for patients with multiple myeloma and compare the group who got the auto-allo versus folks who got double auto transplants with comparable regimens in terms of the high-dose melphalan. Suffice it to say that when the Italians did this trial, you saw a substantial benefit in terms of treatment-related mortality, not surprisingly, the patients getting autologous transplants had a lower treatment-related mortality. But if you look at the complete remission rate, overall survival, and progression-free survival, all of these things really favored getting the second allo transplant, if you will, because, again, that then gets the immune system in place and so maybe kills some residual cells, which just giving somebody back their own cells twice isn't necessarily going to do. Having said that, and this is what the curves look like. This is the event-free survival curve. This is the overall survival curve from this Italian data, and it looked pretty encouraging. Now, of course, everything's not really simple. This is what the French showed a couple of years earlier, and in fact, unfortunately, they looked at 150 patients, and this would be the group that you really think might benefit from the allogeneic transplant because they were higher-risk myeloma patients. And when you got right down to it, what you see here is that there really was no benefit for the patients that got the auto-allo versus the double auto. The overall survival from the time of diagnosis was 52% versus 54%, and the event-free survival was actually shorter for the people getting the allograft than the people who got the double autologous transplant. So I think that it still is a question who you should refer for an allograft for this disease. There is a big U.S. trial that's now been completed. It's probably going to be a year or two before we have results from that. But I think that we're continuing to try to figure out how we can convert some of these durable remissions into actual cure in patients with myeloma because it's otherwise still a fatal disease. Now, looking at some of the overall data here, this is from the IBMTR. We're looking at identical sibling data, and this is for patients with acute myeloid leukemia. And these are folks that were treated in the late 90s. And so this is the data for patients getting a first remission transplant. And this is not randomized data. This is registry data. So this is from people sending in their reports from around the world to this CIBMTR registry. And if you look at patients in first remission who got an identical twin transplant, this dotted line here is people in second remission who get an identical twin transplant. So you see about a 20% difference between the folks in first remission or second remission. And while you'd say, well, geez, maybe we should transplant everybody in first remission, but some of these folks never need a transplant. And so that's why, part of the reason why there tends to be a higher cure rate, because not all of these were necessarily high-risk patients. If you look at the unrelated population, however, the numbers are not quite so good. They're around a 40% durable remission rate in patients that are either beyond first remission or even in first remission. And part of this is the fact that you have some increased complications, and that's why your risk for survival is going to be a little bit less than is the case for a sibling transplant. But also, as you see here, when you get out into higher risk disease, it's not so much whether you've got an identical, HLA identical sibling that's used as your donor. It's really the fact that bad disease tends to be associated with a worse outcome. And so as we look at patients who are higher risk, we don't pay too much attention to whether they have a related or an unrelated donor. If we think they have bad disease, the data suggests that they should get a transplant. So we transplant them as long as we can find a donor, whether they be within the family or outside. This is, again, looking at folks over the age of 18 by disease state. This is what the data looks like for folks in first remission or second complete remission, so really not a whole lot of difference here. And again, this is looking at patients, all adult patients, so the previous slide was looking at adults and children. It was a combination. This is in folks who have more advanced disease, and again, even though you're on a plateau out here and these people are probably cured, that's only about 15 to 20% of the population because they have a higher risk of recurrence of their leukemia. Now, what about folks with MDS? This kind of gets to the issue of you don't want to wait too long. If you wait for all of your refractory anemia patients to develop excess of blasts or a higher risk population, you're going to tend to do not so well. And so these are the folks who have an identical sibling match who have refractory anemia or that with ring sideroblasts. This is their curve. If you look at the unrelated population, this is here in yellow. So you've lost about 15%, but again, these are older data from the late 90s before we were routinely using the better typing. So I would say right now these two curves are going to be closer together than they were when this data was generated 7 and 8 years ago. If you look at patients with unrelated disease, or if you look at people who have RAB-T, excess of blasts, this is a higher risk population, and you're looking at a curve there that's between 35 and 40%. And so if you wait for folks to develop the more aggressive disease, they're not going to do as well. And this is a population that is not going to be cured with any standard therapies now, so one can make the case that you should probably be transplanting folks fairly early with this disease, but you want to look at the risk factors that we talked about before, cytogenetics and things like that, before you actually recommend taking them on. Now, what about the adult patients over the age of 18? Again, looking at the subtypes, people with excess of blasts or RAB-T don't tend to do as well as folks with less advanced disease, and this is what the two curves look like. So again, timing is important here. And if you look at cord blood transplants, and this is people under the age of 18 up here, and these are folks over the age of 18, and these numbers are really pretty small. This is only 48 patients. This is only 169 patients. And if you combine them, it's 217. But if you're talking to a 40-year-old, you can't look at this curve. You've at best got to look at this curve. And so I think that's where cord blood transplants are these days, and we're still trying to make them better before we say that this is an option that everybody should consider. Now, the next few slides I'm going to look at is just a little bit of a summary, and that is when we talk about what kills patients after they've undergone a transplant, it really depends on what it is that they're being transplanted for and how they're being transplanted. So in patients who are undergoing autologous transplants, the great majority of people who fail after an autologous transplant do so because they have a recurrence of their underlying malignancy, so they relapse their disease. On the other hand, whether you're getting an identical SIB transplant, and I don't mean a twin, I just mean an HLA matched sibling, or whether you're looking at a well-matched unrelated, then in fact the relapse percentage is only about a third of this group, and it's even a little bit less in this group. And it's all these other complications, graft versus host disease, infection, graft rejection, and so on. So when you look at an allogeneic setting for either of these two groups, you really have a lot of room to improve the non-relapse component as well as the relapse component to try to improve your overall outcomes for this group of patients. And so to that end, I'll just briefly mention that one of the approaches that we've taken, as well as a number of people, are using less intensive doses of busulfan along with a drug called fludarabine. We use a drug called alemtuzumab or Campath, and we're now switched to ATG as an immune suppression for these patients to try to reduce the risk of GVH. And if you just look at our own summary of 27 patients, 15 of whom had unrelated donors, a median age of 56 in this population of patients, we have a relapse-free survival rate of about 42%. Now, this is all comers. Some of these are AML patients that are in remission. Some of these are people with follicular lymphomas, but it's about 40% at a year and a half, and the overall survival is over 50%. So some of the folks, even when they recur after this approach, can still be salvaged because these are patients that, for the most part, are in pretty good shape. LCCC stands for Lineberger Comprehensive Cancer Center, and so this is an IRB-approved trial that we have open here. So that's kind of looking at the older population, people who might have some underlying comorbid illness. But what about younger people for whom you know that relapse is going to be an issue and they could handle higher doses or more intensive treatments? And so one of the things that we've been doing, and this is some work I've done with Chris Walco from the School of Pharmacy, is looking at whether or not you can give a test dose of the drug busulfan and correlate this with the actual dose that they get during their continuous therapeutic infusion. And so we give people a test dose, measure their PK, a week later bring them back in and actually give them a therapeutic dose based on the pharmacokinetics of what they've cleared, on a week before. And what you can see here is that quite accurately you can predict that how they cleared the drug on 1 week is going to predict for how they're going to clear the drug in the next week without a lot of variability. So now the second part of this is to say, okay, so now we know what precise dose of drug we want to give patients. And so even though this shows you that the same dose of drug can give a threefold difference from patient A to patient B, what it also tells us is that once we know where we're starting, we can predict pretty well for where we're going to be a week later when we actually give them the higher dose. And so we've now done a trial that is nearing completion, and we're currently giving a dose of busulfan that is almost twice what the standard dose is, because we've gotten rid of a lot of the variability by doing this kind of an approach and by giving the drug as a prolonged infusion rather than as a 4-time-a-day intermittent infusion where the peaks and valleys are associated with more toxicity. So whether or not that's going to turn out in the long run to be a more effective approach, we'll have to see. But this is what some of our data has looked like now, looking at the first 43 patients that we've treated with either that prolonged infusion or with the targeted therapy. And you're looking here at patients who got either an unrelated or a related transplant here in blue. And you can see here that the curves look pretty good in the range of 60 to 70%, but this is fairly short survival time. And I can tell you that these curves have continued to drift down because patients have ended up with recurrence of their disease or dying later on from GVH and so on. But perhaps the most important thing is that even with this intensive approach, we only had one patient out of the first 43 that we treated this way who died within the first 3 months of transplant. And so when you're doing donor transplants and you can give people numbers like that, then I think that at least says, well, it's worth a try because I know that I'm likely to get out of the hospital, and then we'll see how we do with our eventual outcomes. When we look at how we've done with our myeloma patients, and this is some work that was recently presented a year or so ago at the ASBMT meetings, we looked at 110 myeloma patients treated with a standard approach. Another 10 patients were treated on a trial where we used melphalan and a drug called mitoxantrone. We didn't transplant them twice. We only did it one time. Everybody got their cells collected after their similar mobilization therapy. And this is what our survival looks like for folks with multiple myeloma since the year 2000. And I don't want to make too much of this because I don't know that we're curing patients. But again, when you look at this, what it tells you is that we haven't come close to what our median survival is with a follow-up now of over 4 years for the majority of these patients. And so I think that we're getting close to a 50% survival that's probably going to approach 5, 6, 7 years. And, if you had myeloma 10 years ago, that was a pretty different story, where our median survival for folks with stage 3 disease was in the range of 2 or 3 years, not in the range of 6 or 7 years. So I think that we are making progress, and I think that, this data has been demonstrated by certainly other groups in addition to ourselves. What about our results in folks with autologous transplants for non-Hodgkin's lymphoma and Hodgkin's disease? So treating patients who have had high-risk disease, for the most part using a chemotherapy-only regimen, but a smaller percentage of people who've gotten radiation-containing regimens. And this is what the data has looked like. So if you can get people under pretty good control before you take them on to their transplant, I'm certainly much more confident that this is a true plateau here in the range of 60 to 65%. And so I think that if we really can cure salvage patients with lymphomas to this degree, I'd like it to be 80%, but this is much better than the 30 to 40% that it was 10 years ago. Part of this is the availability of rituximab, the antibody, the CD20 antibody has really been huge and has made a big difference, I think, in terms of how people have done both with and without transplantation. Now, to summarize our own 100-day survival, patients getting autologous transplant, we have about a 97% 100-day survival. The 1-year survival for folks getting autografts is 84%. And in the donor setting, our 100-day survival is 93.6%. And that combines both related and unrelated donor transplants, probably about half and half at our center. About half of our donor transplants are unrelated and about half are related. And then if you look at our 1-year survival, it's about 67%. These are very different groups of patients, and so 67% is actually pretty good for a group of patients mostly who have high-risk myelodysplasia or advanced leukemia. Now, looking at the numbers of our patients undergoing transplant here at UNC over the years, we only went back to 2002, and it's a little bit of a, well, it's a colorful slide, I'll put it that way. But basically, the purple here are folks getting autologous transplants. The green are people getting allogeneic related. The yellow is the unrelated population. And then the pink here is adults, and the orange here is kids. And so the numbers at the top are just the aggregate numbers. So in the early 2002, 2003, we were doing 60 to 70 patients a year. And then starting in 2005, our numbers have increased quite a bit. And now in this past calendar year, we went up to 113 patients that we've transplanted. And out of that population, about 1/3 have been allogeneic and about 2/3 have been autologous. And so this year, we're already sort of increasing our activity and have been seeing substantially increased numbers of referrals compared to what had been the case even 3 or 4 years ago. So I think a lot of that is contracting, and some of that is just having a stable group that's been around for a long time. Referring physicians now know us and for the most part trust us and are sending the patients our way. And so with that, maybe given the time, I'll go ahead and stop. I do have some case studies that we can talk about, but I think it's really just more things like, what you need to worry about as a late, as a physician who is going to be caring for some of these people late after a transplant. And I would say that at things like graft versus host disease, if somebody has pain in their hip, think avascular necrosis. If they've been on steroids for a long period of time, think osteoporosis. So think the kinds of things that may not be related even necessarily to GVH, but could be a long-term sequelae of what they might have had 5 years earlier. So with that, I'll go ahead and stop, and if we have some time, I'll be happy to take questions. Thanks very much. Gene?
Tom, with your advent of more low-intensity therapy, are patients spending less time in the hospital? Are they charged? Are there
Sure.
benefits to that?
Yeah, some of that is a little bit depending on how the centers are set up. And so we have not traditionally done a lot of our patients as outpatients, and the economics of our region have really not mandated that. We've had a number of people that have undergone an initial transplant at Duke, recurred, either their insurance changed or whatever, they've come over here, and then they've undergone their second transplant through our center. And for the most part, patients like being in the hospital when they're sick, rather than having their spouse have to take 2 months off from work and actually give them bedpans and things like that. So I think that, the issue of how much time you spend in the hospital versus outpatient, really depends a little bit by center. But having said that, our median time for an autologous patient now is probably about 16 to 17 days in the hospital, and for allogeneics, it's about 22, 23 days. And so, back when I first started doing this 20 years ago, autologous transplants were in the hospital for 2 months, and, it's quite a different story than it used to be.
How about chronic lymphocytic leukemia? You didn't say much about it.
Yeah. I think CLL is a disease that, we tend to think of as chronic, and it is, but there's certainly subsets of CLL, for instance, those with the, abnormalities of chromosome 17, the P53 abnormalities, who have really very aggressive disease. And so there's going to be a national trial that is actually going to be looking specifically at the P53 abnormal patients and trying to transplant them with allografts in first remission. We've done a handful of CLL patients, and I would tell you that maybe we're waiting too long, but our CLL folks have been tough. Not only do they get sick, but at least in a couple of cases, fairly shortly after we've transplanted them, they've recurred, and in at least one case kind of transformed and came back with the lymphoblastic leukemia, at day 100. So I think that CLL, is really one where you have to look closely at the prognostic factors. And of course, if you only take the biologically real severe or advanced cases, then your numbers are not going to look good. I think the follicular lymphoma population is a group that we probably can have a better sense of how helpful we can be with them now. The CLGB data that I was alluding to, that I was involved with, we have about a 63% 4-year disease-free survival on that trial. A group from MD Anderson using a lot of rituximab, but otherwise a similar approach, have an 80% 4-year, actually 5-year disease-free survival for follicular lymphomas. And so I think that for that population of patients, I think that, we're probably should be doing more transplants. I think for the CLL population, it continues to be an issue, but even the folks in Houston, who by and large were not big fans, have said, we should be doing more transplants for CLL because even though it's indolent, it's still a fatal disease for folks in their 40s and 50s and 60s. So. Anything else? I guess it was crystal clear. Thanks very much.